All right, hello everyone. Thanks for joining us. We'll just give everyone a few minutes to filter into the room, and then we'll get started. All right, looks like we have a decent number of folks here. So thanks so much for joining us, everyone. My name is Karen. I use she, her pronouns, and I work for the Canadian Public Health Association, and I'll be co-moderating our webinar today along with my colleague Pauly, who will be helping out with the Q&A and any technical things that arise with the webinar. And so while we're working remotely, I want to acknowledge that I'm currently located on Treaty 7 territory, which is the traditional territory of the Blackfoot Confederacy. And I would also like to acknowledge that CPHA's office is located on the original unceded territory of the Algonquin Anishinaabe people. They've been the guardians of this land for millennia, and CPHA is grateful for the example that their stewardship provides. CPHA is committed to working with First Nations, Inuit, and Métis people and their governments in realizing meaningful truth and reconciliation. So with that said, we can get started with today's webinar. So if we can move to the next slide. So just a bit of housekeeping before we get started. Everyone's muted, but we encourage you to make use of the chat and Q&A functions to interact with each other and to ask questions of the presenters today. So the format for the webinar will be a presentation followed by a Q&A period. And so we hope to have lots of time to be able to answer all of your questions. If you have any general comments, I think the best place for those is in the chat box. Make sure you select all panelists and attendees if you want to be able to interact with other folks. I think the default is set to panelists, which means that we'll be the only ones who can see your comments. And then if you have any questions for the presenters, please post them in the Q&A box. You can also give thumbs up to each other's questions if you see questions that you see that are particularly important. So we encourage you to use the Q&A function for questions instead of the chat. And we also wanted to let everyone know that the webinar is being recorded and that it'll be available on our YouTube channel in the coming week or so. So not to worry about that. And with that, I will introduce the webinar we'll be doing today along with the panelists. So as we all know, there is an urgent need to address the devastating losses associated with the current drug poisoning emergency. And the presenters for today's webinar, they undertook a concept mapping study to obtain the perspectives of service users on key elements of effective safer supply programs. So the webinar will present a model of safer supply informed by people who use drugs and include recommendations for programmatic and systemic changes. So to introduce our presenters for today, Fred Cameron is the Operations Coordinator and Harm Reduction Manager with the Solid Outreach Society. He has extensive experience as a community researcher with the Canadian Institute for Substance Use Research. He is a member of BC Strategies for Patient-Oriented Research, Patient Council. He is an author and a writer who has published on patient-oriented research and peer-led interventions, as well as other current issues in local and regional magazines. In addition to working with Solid, he's completing a degree in social work. Our other presenter for today is Dr. Bernie Pauly, who is a professor in the School of Nursing, a scientist at the Canadian Institute for Substance Use Research, and a University of Victoria Community Engaged Scholar. She's the current Island Health Scholar in Residence, a position she has had since 2016. Her research focuses on reducing health inequities in the context of substance use and homelessness and promoting health equity through more equitable systems and services. She's been a research collaborator with Solid Outreach and AVI Health and Community Services for more than 15 years. Her work has been recognized with numerous awards, including the recent BC Health Employers Association Diana Maud Jones Award for Excellence in Person-Centered Care. So thank you so much, everyone, for joining us, and thank you to our presenters for joining us today. And with that, we will turn it over to them.
Thanks so much, Karen, for the introduction. And Fred and I are really pleased to be here today to share with you this study that we worked together from our roles as an academic and community researcher, and a part of our long collaboration between our university and our institute with Solid Outreach, which is a peer-led, peer-run service for people who use drugs in Victoria. You can see that we also have a team that includes community researchers from AVI Health and Community Services, as well as other academic researchers. The University of Victoria stands on the traditional territories of the Lekwungen peoples, and we acknowledge with respect the traditional territory where the university stands, and specifically the Songhees, Esquimalt, and WSÁNEĆ peoples whose historical relationships continue with the land to this day. And we are always very mindful in our work to think about how we are hopefully helping to address inequities that have been produced by colonization, and to not reproduce those inequities. When we planned this presentation, I did not fully appreciate that we were also giving this presentation on a day 5 years after the declaration of a public health emergency in BC. 20,000 Canadians have died of an overdose. 7,000 of those have been in BC, and that's been in the last 5 years. In British Columbia, we have approximately more than 5 people who are dying per day, and we've actually seen reductions in life expectancy due to, and I'm not going to call it an overdose emergency, I'm going to call it a toxic drug policy emergency. And it's affected people all across this country, but BC, as you can see, has been particularly affected. And today we will be standing later at the legislature to acknowledge the losses, but also to acknowledge what can and should be done. And we hope that the presentation we give you today also gives you some insights. I'm going to turn it over to Fred.
Thanks, Bertie. The toxic drug supply combined with COVID has led to increased overdose deaths. Risk mitigation guidance introduced early in the pandemic was to address the dual emergencies. To support service providers in providing care to people who use substances with guidance for prescription of opioids, stimulants, benzodiazepines, and other drugs, or referral to managed alcohol program, was implemented a little over a year ago. But the major flaw being there was limited guidance related to how to implement the program. People who use drugs should be involved in the decisions that impact their lives and are central to overdose response and efforts in BC. This commitment to meaningful participation of people who use drugs in overdose responses is outlined in many provincial documents.
And much of our research over the past few years has identified the way in which services designed for and by people who use drugs have been key to effective services, as well as operationalizing a core principle of harm reduction, nothing about us without us. And you see here one example of an overdose prevention site in British Columbia that was designed with people who use drugs. Since the risk mitigation guidance was released in March of 2020, in 2020, as Fred mentioned, there wasn't a clear implementation plan, but a number of service agencies in Victoria, Solid, AVI, and ourselves collaborated on an application that was put to the Substance Use and Addiction Programs of Health Canada, and it resulted in funding a few months into the dual declared overdose emergency. And immediately the risk mitigation guidance, which was released by the province, was taken up in what was called the Vic Safer Initiative. As part of that VicSafer initiative, and our role at the Canadian Institute for Substance Use Research was to support research related to this initiative of the Safer Supply program known as VicSafer. And one of the things that was specifically asked of us by service providers and people who use drugs was to be able to do some initial research to inform the program from the perspective of people who would use the program. And so one of our partners said, you know, what about really getting their perspective on what would be effective, safer supply? And so our primary research question is, what is effective, safer supply from a service user perspective or the perspective of people who use drugs? The definition that we use in the research of safe supply is the definition that has been developed by the Canadian Association of People Who Use Drugs in their Safe Supply Concept document released in 2019. Safe supply refers to legal regulated supply of drugs with mind-body altering properties that traditionally have been accessible only through the illicit drug market.
So personally, I've been working with Bernie for a little over 4 years now, I believe. And currently I'm sitting on the BC Support Unit Patient Council. And I just have to say that my involvement in the research process has been like a life-changing opportunity. I came in after about 25 years or so struggling with addiction, and I met Bernie as a resident at a recovery facility. At the time, I was an unemployed roofer who hadn't been to see a doctor in a little over a decade. And figuring out why I didn't trust the healthcare system was near and dear to my heart and my survival, I guess, even at that point. So having this opportunity to come in and work with Dr. Pauly led to me working with the Umbrella Society, which I then transitioned over to Solid Outreach. And since then, I've moved up steadily within the organization, and I've been able to utilize all of the skills that made me successful as a tradesman and restaurateur in my youth. So, you know, having patients involved has so many benefits. First off, you know, we bring the information directly out to the community. But, you know, that leads me to the question, why patient-oriented research? And engaging service users in the research is essential in order to ask the right questions, as well as to inform and ensure good processes in the research and ultimately improve health services. Shifting from researcher-driven research to patient-oriented research is central to SPORE. Our approach to patient-oriented research is community-based participatory research. So it's not just patient-driven, but also community-driven. Participatory community members share control of the research agenda and are involved in all aspects of the research process. It's also action-oriented, so the research is used to make change. Community-based research is seen as particularly relevant to ensure that programs and services are designed from the user point of view, as healthcare providers and decision makers often don't have access to everyday knowledge and experience of people who use the programs and services. So that leads us to our focus prompt. So within community-based participatory research, we used a methodology called concept mapping. We, academic and community researchers together, work to create the focus prompt, which is critical to guide the brainstorming process. We did 3 rounds of focus groups beginning in September of 2020. The first to brainstorm statements, and we generated more than 350, which we later reduced to 68 key statements by eliminating duplicates. In the second group, the 68 key statements were printed on cards that were sorted by individuals into groups, ranging from 2 to 10 groups, as they saw the statements relating to one another. Participants are instructed to sort subjects. Oh, sorry. The third group is for participants to rate the statements as well as assist in the naming of the clusters that were generated from the sorting.
So I'm going to just share with you a bit of who participated in those three groups. And we had in the brainstorming group, we had 35 participants. We had 7 focus groups over a period of September, October 2020, which was a period of time in which we were able to actually do focus groups during the public health COVID emergency, obviously with special precautions. We took great care to do focus groups in a variety of settings. Some of them were done in overdose prevention sites. Some of them were done in hotels or housing, some of them in outreach organization and settings. And probably for me, one of the ones that was a new venue was we did one in the park. In one of the parks here to engage a full scope of people. So you can see that we had people from a wide range of ages, from age 18 to over 65, with a majority being 35 to 44. We had people who identified as male, female, trans, or non-binary, and you can see the breakdown there with a slightly greater proportion of males. We had people who identified as white, Indigenous, and you can see the proportion that we had in terms of that. Wide range of education, with most people falling into some high school. We had people in different housing situations, from living without a fixed address in a park, to a shelter, to living in an SRO, to a renter, and in a few cases owner. You can see that most people, or more people, describe their housing as stable than unstable, but we've had a fairly large proportion that also said unsure as well. So these 35 participants, some of them returned for the second group, but we also were able, because in the sorting, we were also able to engage a larger number of people through solid outreach. We also had some new participants. And in the third group, many of our initial participants from group 1 and some from group 2 returned, and in total we had about 68 people who participated in the concept mapping process. So we use a software program that allows us to do multidimensional scaling, where the way in which people sort the statements, that was what Fred was describing in the second group, where all the 68 statements that were generated from the brainstorming, all 68 were placed on cards, which people then sorted. And what the point map shows is how people sorted the statements in relation to each other, and how frequently statements occurred together. And this is sort of what is initially generated from the concept mapping process using multidimensional scaling. And then I'm going to turn it over to Fred, and he's going to explain to you how we got to 6 clusters. Oh, Fred, I think your microphone's off.
Thanks, Bernie. I'll try this again. So we had examined various numbers of clusters. So we looked at options from as high as 12 different groups and as low as 4. And we would go through the statements in each model, and we identified 6 as being the strongest. So we'll go through the clusters, starting with cluster 1, which we entitled "Right Dose and Right Drugs for Me," and the statements being, if drugs are strong enough and doses are high enough so I don't have to add street drugs to give it legs. Access to combination of drugs, for example, if you need both up and down. don't want to be dependent or too hard to get off of, provides a safe and non-toxic supply without the side effects. I can try different things to see what works. If cannabis was part of the program, having more options and choices of drugs such as heroin, fentanyl, morphine, ketamine, cocaine, and the original methadone. If drugs were decriminalized, if drugs were available in vending machines, if drugs were legal, if there was actual heroin because it lasts longer and helps with PTSD and mental health. If it was something I could inject, if it was something I could smoke, if I had the right drugs in the right dose to achieve the euphoric state, if fentanyl was available, including fentanyl patches and powders, if it was the same as real dope, if they reversed Dilaudid and Cadian prescription.
The second cluster is entitled Safe, Positive, and Welcoming Spaces. Tell the media when something good happens. There's somewhere to go and someone to talk to and check on you. The program isn't short term. It doesn't make addicts or use to control us. You're not labeled or stigmatized as a drug user or labeled as a disorder, as having a disorder in order to get help. There was a team with peers on it, mental health supports such as optional counseling. The sites are available 24/7. There are separate places for smoking and injecting. I felt nurtured, not just given pills. People believe what you say, and the program is welcoming without judgments, stigma, or blame.
Cluster 3, safe supply and other services are accepted. It should be more than a 7-day script. No shortage of drugs. Access to housing, survival supplies, and services, for example, showers, food, and other essentials. Options to recreate the ritual. There was drug checking. No police. There is no urine testing. If it were like a safe injection site. It was easy to access, and I do not have to jump through hoops.
Cluster 4, I'm treated with respect. There was respect and trust. There are people who communicate well and follow through. Having an earthquake, having an earthquake emergency supply on hand, treated like I deserve care and feel safe. There are people who are relatable and who understand what you're going through, knows me as an individual, and merges a lot of different services together.
Cluster 5, I can easily get my safe supply. It gives the opportunity, it gives priority and care to both stimulant and opioid users. If there was an incentive, prescribers who understand dope, consistent and stable medication delivery, options to housing, hotels, and parks, caring doctors. There are more sites and locations you could go to. I do not get cut off, or my dose is not dropped for missing days. If I was trusted with the prescription, more than a daily or weekly supply, for example, drug carries. I had more information about safe supply. I had, peers who have experience with drugs and are like me. It was provided in a therapeutic environment. Personalized and individualized supply, listens to the patient's needs. The program comes to me with outreach or mobile options. Access to doctors and nurses who can prescribe and provide medical care.
Cluster 6 helps me function and improves my quality of life as defined by me. It should help stimulant users and something for crack and meth. No daily witnessing or daily pickup, and daily pickups were on site where you live. There was something for chronic pain, alternatives to get that monkey off your back and improve your life. Other options besides Suboxone. Suboxone is not enough and people get sick of using. Drugs that get you to normal or help you function. There are other treatment options or next steps. I do not have to pay for it.
So this is referred to as the ladder map, and it shows each of the groups as ranked in terms of feasibility and importance. As you can see, all of them are fairly closely grouped together. So on a 4-point scale, I think they were all between 3 and 3.5. I'll pass that on to Bernie.
From when you use concept map methodology, you can also create Go maps, and you'll see the vertical line and it shows importance in terms of 3.3. And so look to the right of that. And then in terms of feasibility, you can see the line that says 2.97. And you can see above that, it creates a green space, which is identifying items that are both high in terms of highest, sorry, I should say highest, because as Fred noted in the previous slide, almost everything was high, but the highest are in the green square. And you can see the clustering of statements from those various, from the 6 clusters really, that make up the statements that are both high in importance and considered high in feasibility by the participants. And I think what, if you look at some of those statements, you can see that many of them have to do with how people are treated in a respectful way, and relate to addressing issues around stigma. And it doesn't quite come out here, but when people talked about people who have experience with drugs and people like me, people mentioned throughout a really important aspect of the model is having other people with living experience of drug use. And Fred's going to share with you the top 5 statements for importance and feasibility.
Well, all the statements rated above 3 in terms of importance on a 4-point scale, these are the top 5 statements. Prescribers who understand dope, not labeled or stigmatized as a drug user or being labeled with a disorder to get help. There is something for chronic pain. Consistent and stable medication delivery options to hotels, housing, and parks. Access to doctors and nurses who can prescribe and provide medical care. People identified that being treated with respect and without judgment is highly feasible or should be easy to do. The top 5 statements ranked for feasibility. I had more information about safe supply. Treated like I deserve care and I feel safe. Access to doctors and nurses who can prescribe and provide medical care. The program is welcoming, without judgment, stigma, or blame. There are people who are relatable that understand what you are going through.
I'm just going to highlight for a minute a few of the strengths and limitations, and then Fred is going to end with some of the conclusions from the research. People had a wide range of experiences with illicit drug use and safer supply. So they're speaking from, there's actually a broad expertise with different types of drugs and different types of access to safer supply that's being reflected in the model. The model, we tested it for goodness of fit, and it was within recommended ranges for concept mapping. However, there's a number of limitations. We did this in an urban setting, so it doesn't necessarily reflect differences or important aspects for people living in rural or remote settings. And although Indigenous people are represented in the sample, we haven't specifically addressed their needs, and sex and gender considerations are not explicitly pulled out and identified as well. And Fred's going to highlight some of the conclusions. And one of the things that we did, in addition to working with solid and, obviously the research engaged a broad perspective of people who use drugs, We also reviewed the research with the provincial network of people who use drugs, BC Yukon Association of Drug War Survivor representatives, as well as BC CDC members of the PEEP, which stands for Professionals for Ethical Engagement of People Who Use Drugs. And so I'm going to turn it to Fred to go through the conclusions.
Thanks, Bernie. So we spent a whole lot of time going through condensing and eliminating statements, and we came to a few conclusions. People will continue to use the illegal drug market if drugs, dosages, and models of consumption are not adequate or not available. People with lived and living experience should be included at all levels in the design and development of programs. People have a variety of goals for safer supply, including euphoria, pain management, ability to function, and to prevent withdrawal. Outcomes of improved function and quality of life should be defined by the individual. Strategies such as treating people with respect and building trust are viewed as highly feasible and important. Peers are best positioned to build trust. Integration with other services and team approach in a safe and positive, welcoming environment. Delivery of pharmaceutical alternatives should be demedicalized and informed by a harm reduction model by individualizing prescriptions, providing peer and outreach supports with delivery options. Address issues related to daily dispensing and drug carries. Peer advocates should be involved in efforts to resolve issues and barriers at all levels, with physicians and also at a regulatory level, for example. Safer supply should be provided within a broader public health framework that includes decriminalization and models of legal access to substances. Consideration of models such as compassion clubs and regulated alternatives.
Thank you for listening. And I think we have a good amount of time, probably 15 minutes for questions. And I think, Haley, if you have some questions for us to get started, that's great. And we really hope that this can be a discussion that is useful to helping people move forward on some of these very important initiatives around safer supply.
Yeah, thank you so much, both of you, for the presentation today. I see maybe before we have some questions prepared while people perhaps take some time to reflect and consider the question they would like to ask. But I do see, I'm seeing some questions in the Q&A box already. So we do have one question about, we'll start with the easy one, maybe. What software program was used for point mapping?
The software program that we use is it's actually called Concept Systems, Concept Mapping. And it is, I'm going to be honest, it does have a cost attached to it. There are some versions that have been created that are free, and happy if you get in touch with me, as I can send you the links. The beauty of, we were in the fortunate situation of being able to pay pay for the concept mapping software because we've used it on a number of projects. The beauty of that software is it really does do a lot of the work. And I hope it came through in the presentation that it's such, I think it's such a great methodology for truly working collaboratively and engaging people. And Fred can speak to this a bit more because we've all been involved in the focus groups. But one of the things that I often notice is that people really enjoy the focus groups. Fred, do you want to speak to that part of it in terms of the focus groups, and how people feel about them and their engagement?
Yes, generally speaking, I would say it's not a stretch to call the addicted community the most stigmatized group on the planet. So this is a group of people that are not used to being listened to And it is absolutely amazingly freeing to be given an opportunity to speak and be listened to and have those statements be brought forward to groups like this one.
Maybe I'll just also, Fred, when Fred talks, he often reminds me of important things to say, is that we have shared this work with the BC Ministry of Health and BC Ministry of Mental Health and Addictions. Fred and I presented a few weeks ago to them. And, you know, we feel like it's been an important opportunity to share these findings with policymakers and service providers as well. And I think Amanda, who works with us, popped into the chat box a postcard that has the 6 clusters on it that make up the model. And one of the things we've done before and we'll do again is we often take the postcard back. What we do, the whole reason we make the postcard is we take it back to people, and that's kind of been as Fred said, that's been a powerful piece.
Mm-hmm. Yeah, we've seen, like, people are calling us to say, when is the next group going to be? Like, they're so excited to take part. It's wonderful to watch and to be a part of.
Yeah, and I believe the postcard was, I don't know if everyone can see it, so I just recopied the link so that everyone can see it. We have another question here that kind of relates to what we're talking about with focus groups, relating to methodology. Were the importance and feasibility rankings done by participants within the focus group setting or by the research team?
Oh, no, they were done by the participants. So sorry, I should make clear. So as Fred mentioned, we did a second round of focus groups, but the third round of focus groups was when we did the importance and feasibility. But in fact, it wasn't us doing the importance and feasibility. It was all the participants did it individually first. And then we had a focus group where we showed them the 6 clusters and talked with them about the cluster names. So that ranking of importance and feasibility was done by individuals just prior to that focus groups. And that would be all people who would be potential service users.
Okay, thank you for clarifying. And I think we have another question here about, in terms of knowledge sharing with policymakers, were there any actionable strategies for carrying the conclusions forward?
Well, we will wait and see. we just presented to them. I mean, I think Fred presented really clearly all of our conclusions, and there's a lot of actionable strategies there for policymakers and service providers. So yeah, we have to wait and see what happens. I assume that people would know that the British Columbia risk mitigation guidance was initially introduced under COVID and is in the process of being revised.
Mm-hmm. Thanks so much. And we have another question here about, oh, and sorry, Fred, did you have anything you wanted to add?
Oh, I'm good.
Oh, okay, perfect. Just wanted to make sure. Is there any intention of researching or involving family members in the future to get their perspectives of these programs and how they have helped their loved one?
That's a great question. And a very important question. We don't have any specific plans right now. And I know that but I do know there are other people who are working across the country to really reflect and gain the perspectives of family members. Fred, do you want to make any comments from your perspective of, the benefits or challenges of safe supply that you've seen?
Well, first, I guess I'll just mention quickly on the family members, the majority of the peers involved in this have family members or the street community pretty much functions as a family. As an individual, I lost a sister to overdose, and this is something that I have the ability to speak on behalf of my father and my family, and representing her from that perspective. In terms of can you repeat your question, Bernie?
If you wanted to mention, things you've seen from your perspective around safer supply and what's been helpful.
Yeah. For certain individuals, the results have been hugely varied, but for certain people, it has given them the ability to step up their day-to-day function, which allows them to make money and take care of themselves with a huge amount of freedom compared to what life was like prior to getting the safe supply. So over the past year, within our organization, and I don't know how many, but I would guess close to half of the people working under me are on safe supply of some sort. Every one of them has moved out of supportive housing. The majority of them in the past were working somewhere between 5 and 15 hours a week, and they've all increased from probably in the area of 25 to 30 hours. It has just had huge health benefits and improved their day-to-day lives, night and day difference.
And just to add to that, we are actually in collaboration with Solid and many other partners are doing a provincial evaluation of the risk mitigation guidance that was introduced to address dual public health emergencies in BC. And we're also following people to look at the impacts on health, quality of life, and harms related to substance use. And I think, we can also mention the flip side of, things that have been challenges as well of people getting on safe supply, getting right substances. And I think that first cluster just really speaks to so much that I think people have said in so many different ways about right drugs and right dose for me. And it's not a one size fits all. So I think this piece of research really highlights what's needed to be effective and to address some of the shortcomings. And then our provincial evaluation, I think, will further highlight benefits and challenges.
Yeah, thanks so much. We have another question here. I'm going to kind of go out of order because I think it's related to what we just discussed. But what is the best way to engage people with living experience? And I know that's a very broad question, so I have some other things maybe I could add to it, but maybe I'll start with that because that's the question that's been asked.
Pretty sure that's your question, Fred.
Yeah, it is a broad question. From my perspective, it should be involving a peer organization, just because that kind of fosters thought and growth of ideas. If peers are interchangeable, researchers can pretty much cherry pick who is there and they just get an echo of their own ideas. So having a group of people that are able to sit in a room together and bounce ideas off of each other. So probably, number 3 or 4 maybe is the right number. Too many, the quietest ones are drowned out. But they should have the opportunity to grow. So coming in initially, most people who are living in in the street community, just as one example, aren't going to be ready to engage in this process from day one. So it should be brought in slowly, allowing them to grow as a group and figure out how the whole process works. I can just speak from my own experience. I didn't have a clue. I just came in and argued with everything Bernie said. And now we're good friends and I've made a career of it, obviously, as I pointed out earlier.
He did argue, not just with me, but with everybody. And we have some really, really good discussions. And I think what Fred highlighted around, the number of 3 to 4 people, and I think, Fred, you're speaking specifically about on the research team who are doing like the data collection and whatnot. Seemed good.
Yeah, like oftentimes we only had 2 in the recent months, and that was not enough. And then we tried as many as 6, I think, at once, and that was too many people talking at once. So ideas didn't have an opportunity to grow. But over the years that we've been working together, somewhere 3 to 5 maybe is have a broader group than I had initially said. Yeah.
And just to put that in perspective, my colleague, Karen Urbanowski, who's a CSER scientist as well and a CRC chair, we think our measure of success is that if there's more people in the room who identify as people who use drugs and service users, then we see that as very positive, more than there are academics. And I think in one of our previous projects, Fred, we had probably 4 to 6 people from 2 different organizations of people with lived and living experience. And then there was 2 of us plus a research assistant. And so I think from a researcher perspective, for me, it's about developing the relationships. I have worked with Solid for about 15 years roughly. And I've had that privilege and opportunity to work with many people, and totally we partner on the research. So it's not just engaging single individuals, it's engaging with a community.
And I have kind of a related follow-up question for that. So when folks are engaged, I was wondering, what are some strategies or principles that that the people here listening on the webinar can keep in mind in order to ensure that the perspectives, the experiences shared by people, the knowledge shared by people is actually integrated into safer supply programs and other programs? So I'm not sure if that's if that question makes sense, just let me know.
Do you want to start, Fred?
No, you first.
Oh. Okay, I'll try. I think there's 2 parts maybe to the question. The first part is reflecting, how do you ensure, for me, the first part is, how do you ensure that you honor, respect, reflect what your community partners are saying? And I feel very strongly about this, that the community-based research process as a form, and I think Fred did a great job. I think Fred just does such a beautiful job of laying out how community-based research is a type of patient-oriented research. But it's different in the sense that it engages and we work together. So the decision to even do this project, like when the Health Canada grant was put in, it was put in for the Vic Safer initiative. It wasn't me that said, let's do a concept mapping. In fact, I'm the researcher, I didn't even think of it. It was actually one of the community partners who said, hey, what about that concept mapping that we used before? Because we had developed our team together with Solid and Umbrella, 2 organizations, had developed a model of safer primary care for people who use drugs, which used a very similar process. And someone said, hey, what about that concept mapping that you did before? It seems like that might really work here for, service user design. And so I tell that story because I think it's amazing that the community through their experience of research is advising and recommending, the methodology, right? And the questions that were asked, were designed by people in the community. And I think, I'm not going to capture this as well as Fred says it, but Fred says, Fred, if you can remember exactly how you say this, please correct me. Fred said, we're doing the research and you're just making sure that we do it rigorously.
I think you ensure that proper science, I think was the wording I had used, but something along those lines, yes.
Yeah, so yeah. I think that's the partnership, right?
Mm-hmm. Oh, absolutely.
Yeah. And then the second part of that question, I think, has to do with how do we get these findings? How do people now who are in policy and service provider roles, how do they reflect on or and engage the perspectives of people who use drugs? And I would say they have to, I mean, I could just imagine, I don't know, maybe Fred, you want to jump in after this, but I would say, I could totally imagine, the way in which respectfully engaging people who use drugs and designing local services would be the next logical step.
Yeah, absolutely. There's so much missing right now, and it's wonderful to have a sociological push and, trying to diversify services that are out there. But for myself, looking at it, it's not addressing quality of life enough. So other people have completely different needs from what I would have asked. So it's absolutely imperative that we have as many voices as possible involved in this process. Because as somebody that was 100% reliant on service providers, I simply would not engage with them a lot of the time because I just didn't see eye to eye on day one, and that would cause me to change direction for a period of time. So it's such a difficult group, such a diverse group that we're trying to reach right now, and we need to get as many voices as possible. Just asking the right questions.
Yeah, thanks so much. We have one more question here that I want to make sure we have time to get to, so maybe I'll ask it now. Many in community are not supportive of safer use and supply, yet are critical of people who use drugs. How do we overcome this hurdle? I know it's another big question, but I think it's an important one. So
get over it. Fred, I don't know what, I mean, I just see it's about the systems that embrace so much stigma, and people who are working in those systems need many do have the awareness and understanding of how drug policy has created the stigma and the criminalization, but then you have to reflect within yourself and honestly recognize what's going on.
And I would say from experience, so much of the psychological damage came from hiding and just the grind of having to go out and come up with $20 when that didn't seem like a possibility in the morning, and feeling like people are watching. All of that stuff would be taken away by having a readily available regulated supply. The world would change entirely. It would be a slow process, so anyone expecting immediate results is going to be disappointed. But this would be a community change, and the whole culture would shift if we actually were able to get an adequate, safe supply out.
And remembering that people's lives are at stake. These people are dying. People's lives are at stake. And I just feel it's so heavy today because it is the 5th year in which we are in a declared public health overdose emergency.
And one thing that hits me really hard when I look at these current numbers, the numbers had been going down steadily. We were around 100 deaths a month, which is a ridiculous number, and incredibly sad, and it's embarrassing to say almost. And that was a victory. We had moved the numbers down significantly, and we had 170 in a 28-day month. It's just off the charts. So our efforts were moving us in the right direction. The numbers were getting better, and then COVID hit, and the world got flipped upside down everywhere, and particularly hard in this vulnerable population.
Recognizing that we have 1 minute left, there is one more question in here that I think we maybe might have time to get to, if that's okay. So how has this study been connected to the prevention of accidental overdoses in BC? Meaning, has your work led to changes in services that has reduced overdoses in private residences?
I think we kind of answered it earlier when we talked about, we have shared the findings with policymakers and service providers actually across the province. And I think the next step is for them to take it up and through, other research, look at the impacts of those efforts. And specifically, we're continuing to work together in the Health Canada Vic Safer project to look at the impact of that program specifically, because I guess it's so obvious to us, I should have said this, much of what we shared, it was done as service user design for the Vic Safer initiative. So it's already been taken up, to the degree possible within that program. And there's an amazing, some of you may know the Vic Safer, they've done a few presentations and they have their top 10 list, which is really excellent. And I see so much of, there's so much alignment between that list and the research. If anyone's interested, we can send it to you. I know if you're on Twitter, if you follow Vic Safer, they've been tweeting out their top 10 list quite regularly, but I think that's a very clear example of it being taken up into a program because it was done with a program. It was designed for that purpose. And then the broader application for policy and programs provincially. Thanks everybody for the great questions.
Yeah, thank you so much for the excellent, oh, sorry, go ahead.
No, I was just saying thank you as well, yeah.
Yeah, so thank you so much for the presentation and for all the work that you're doing, and thank you everyone for your attendance and engagement in this really important conversation. So thank you so much. We'll be posting the recording and sending it out to everyone after the webinar. So thank you so much, and I hope everyone has a good day. So thanks.